हाँ ऋचा शुरू करो.
Good evening once again, and I want to wish everyone a happy Guru Ravidas Jayanti. And as on the behalf of IAP West Delhi, I welcome you all to this weekly session of IAP West Delhi, and this is our second virtual CME of this year. And I now invite Dr. Gaba sir, President IAP West Delhi, to please say a few words.
Thank you, Richa. Good afternoon, everyone. Dear friends, as you know, Wednesday afternoon is CMER of West Delhi. And to keep the tradition, our learned scientific committee has selected list of topics, as you know, and they are of interest of a common pediatrician. I hope you all are going to be part of weekly CMEs. Either it will be online or offline or hybrid, but all will be YouTube live. I was discussing with Dr. Vipul just now. We'll all have, all CMEs will be YouTube live for the whole year. Right, Vipul?
Yes, sir.
And I hope you enjoy CMEs and get benefit out of it. Today, first CME will be presented by our Dr. Neeta Kejriwal of Manipal Hospital. I invite Dr. Richa Prasher to introduce Dr. Neeta and the topic also, hypocalcemia in adolescents, which is a very common problem these days. You might have seen in your OPDs. Richa.
Thank you, Dr. Gaba sir. Now, as we all know, the cases of hypocalcemia and vitamin D deficiency has been on a rise, especially in adolescents in the past 2 years, during the past COVID times. So let us now learn more about the diagnosis and management of vitamin D deficiency and hypocalcemia from Dr. Neeta Kejriwal. I invite Dr. Neeta Kejriwal. She is a consultant pediatrician in Manipal Hospital, Dwarka. I welcome Dr. Neeta Kejriwal. Over to you, ma'am.
Good afternoon, everyone. I'm Dr. Neeta. Thank you, Dr. Richa, for your kind introduction. And I really thank Dr. Gaba, Dr. Richa, and whole IAP West to give me the privilege to speak on this platform. And without wasting much time, I will start my presentation. I hope I can keep you all awake and engaged during my presentation. So I'll start sharing my screen. So I'm talking about hypocalcemia. Why I chose this topic, because in last 1.5 years, we had seen some number of adolescents who had presented to us with hypocalcemia, with symptomatic hypocalcemia. They have presented to us in tetany with very low calcium and very low vitamin D, which we had not seen so much in adolescent population, because they have a good reserve of calcium. Their bone mass is very good. The approach to adolescent hypocalcemia is little different, and the main thing is we do not want to miss the underlying cause. It could be vitamin D deficiency, it could be any other cause. So we want to investigate properly with a battery of tests so that we do not miss the underlying cause and we treat appropriately. So what is calcium? Calcium is, as we all know, it's the most abundant mineral in our body. It's mostly stored in the bone, 99%. And only 1% is in the serum. The laboratory and clinical abnormality is with relative frequency. That means laboratorily lab could say that there is low calcium, but there might not be a clinical presentation. It might not be symptomatic. So their lab and clinical presentations could be different. It is defined mostly as total calcium less than 2.1 millimole or 8.5 milligram per deciliter. It stays both in ionized and bound form. We all know that bound form is 50%, that is, it is bound to albumin. So albumin is very important when we investigate for the cause of hypocalcemia, and 50% is in the ionized, that is the free form. The homeostasis, the calcium, the body always tries to normalize the calcium. there are various factors, various organs which are playing role to normalize the calcium. So there is we have to know the pathophysiology, then only we'll know what is the cause of this hypocalcemia. So calcium, low calcium, and we have to see if it is ionized and bound form, and in the bound form it is bound to albumin, and how the homeostasis is maintained. So homeostasis is maintained by parathyroid hormone, vitamin D, hepatic function, renal function, serum phosphate levels, even, and serum magnesium also plays a very important role. I will just explain this chart. So whenever we have hypocalcemia, so calcium, whenever calcium is low, it stimulates the parathyroid gland. When the parathyroid gland, because it will sense the calcium level and it will release parathyroid hormone. This parathyroid hormone will act at two places. One, it will act on the bone to release calcium. That means it will demineralize the calcium, demineralize the bone. Then it will act on the kidneys. In kidneys, it will try to retain calcium. There will be more tubular reabsorption of calcium to maintain the serum calcium, because calcium, it is very important. This pathophysiology is very important because calcium is a very, very important ion. It, it regulates so many cell functions. Very important that it is maintained at the cost of other things. So it tries to reabsorb calcium. Then it increases phosphate excretion, the parathyroid hormone, and it converts the 25 hydroxy vitamin D, which has come from the liver, to 125 hydroxy vitamin D. Now this active form of vitamin D goes and acts in the intestine, which helps to increase our dietary absorption of calcium, and the more calcium is absorbed. And we know this vitamin D, it is present, we get it from the sunlight, it is there in the skin. From the skin it gets converted to 25 hydroxy in the liver, then from liver it goes to the kidney, then kidney it acts on the intestine, then more calcium is absorbed. So whenever this is not there, this vitamin D is not there, again the cycle goes, the calcium is low and this parathyroid cycle starts. So whenever vitamin D is low, the calcium will become low, and this low calcium will start, parathyroid hormone will increase, and this will start acting on bone and in kidney. So all the causes will surround around this. So if there is low intake of vitamin D, then if we come to liver, if there is some liver disorder, there is decreased, fatty thing absorption. Then if we go to kidney, there is some renal disorder, there is this 1-alpha hydroxylase enzyme disorder, then there is some malabsorption in the intestine, again this will be, or the parathyroid gland itself is not working, there is hypoparathyroidism. So all these are the causes of hypocalcemia also. Then there are other factors which affects our calcium, that is albumin, because it is bound to albumin 50%. So when albumin is low, the total calcium goes low. Magnesium, low magnesium, again it acts on the alpha, it promotes the conversion into active vitamin D metabolite. So whenever magnesium is low, the calcium again goes low, and we have to correct magnesium to bring back the calcium to the normal thing. So magnesium plays a very important role in acidemia and sepsis also. There is a hypocalcemia. Phosphate is very important. When there is hyperphosphatemia, again there is hypocalcemia, because there is more calcium and phosphate will bind together, and again it also acts on the enzyme. Then blood transfusions, because in blood transfusions we receive a lot of citrates, and which can bind calcium and cause hypocalcemia. So these are majorly the factors and the causes of hypocalcemia which we encounter in our day-to-day practice. So vitamin D related, it could be a deficiency, it could be a disorder of metabolism. That means the enzyme defect is there, it is not getting converted into its active form. There could be resistance to action of vitamin D. There could be type 1 and type 2 rickets are there. The liver disease and certain drugs, which like anti-epileptic drugs, phenytoins, INH, rifampicin, they all metabolize this enzyme, the 25 hydroxylase, which is there in the liver. So all these can cause vitamin D related hypocalcemia. Then second is hypoparathyroidism. Dijor syndrome will be diagnosed in infancy only, but then autoimmune hypoparathyroiditis or pseudo hypoparathyroidism, infiltrative lesions like hemosiderosis, hemophilia, where there's infiltration of the parathyroid gland, then mutation of calcium sensing receptors. Then there are some idiopathic causes. They all cause hypoparathyroidism or pseudo hypoparathyroidism, but the action of PTH is not appreciated, either due to the PTH is low or PTH is not acting at its receptor. Then hyperphosphatemia. Why hyperphosphatemia could be there? Because milk, there are some the cow's milk also have high phosphate concentration. Whenever a formula provides more phosphate to calcium ratio, there could be hyperphosphatemia, which will again cause hypocalcemia. There are some phosphate containing enemas which can lead to hypocalcemia. TPNs, which has more phosphates. Then some rhabdomyolysis and alcohol. These all cause hyperphosphatemia and are the cause of hypocalcemia. Renal failure, again. Others are malabsorption syndrome, alkalosis, like we have seen in hyperventilation. If the girl is hyperventilating, sometimes they go into carpopedal spasm also. Pancreatitis again can cause hypocalcemia. Pseudo-hypocalcemia is because of albumin. When the albumin is low, the total calcium goes low. It's not a true hypocalcemia, it's a pseudo-hypocalcemia. We have to treat the underlying condition. Hungry bone syndrome sometimes mostly happens after the surgery of thyroid or parathyroid, when inadvertently it is removed, and when it is removed and post that there is rapid mineralization of the bone and calcium requirement goes more, and then there is hungry bone syndrome and there is hypocalcemia. So basically these are the causes of hypocalcemia. These all come in that pathophysiology. That chart is there. So the chart says, wherever that points are there, all those are the causes of hypocalcemia. Whenever there is defect in any step, there could be hypocalcemia. So why this calcium is so important? Most important, it is for bone health. We all know that it causes bone mineralization. Then it is very important for smooth muscle and myocardial contraction. So it inhibits these contraction. It's important for nerve impulse conduction. It activates several enzymes. It's important for cell functions. So these are the functions, and so because these are the functions, these will be the symptoms, because it acts on smooth muscles and cardiac muscles. So there are muscle cramps, there could be arrhythmias, there is pain in the back, thighs and calves, mostly because adverse bone health. There will be difficulty in walking. Then Chauvet sign, that is the facial twitching, again because it is very important for nerve impulse conduction. Rosio sign, that is carpopedal spasm. There could be paresthesias, there could be seizures, there is long QTC. So we all are very much aware about these symptoms. They are not new to us. So hypocalcemia, when it goes seriously to a very low level, then many of the times we'll see when we do calcium, vitamin D as a routine, they may come as low, but they don't present as symptoms. Symptomatic hypocalcemia is more severe, and it has to be treated immediately. So an approach to diagnostic pediatric hypocalcemia. So first we will do a clinical examination. Suppose in the clinical examination hypocalcemia is there. Suppose we get some rickety findings, so we know it could be rickety vitamin D. If we get something like which points towards the renal disease, something which points to the malabsorption syndrome, it can point towards liver disorders. So from the clinical history, we might know a little about the cause of hypocalcemia. Then we'll confirm the diagnosis of hypocalcemia, total serum calcium. Then either we will do a ionized serum calcium, or we will do a albumin. If hypoalbuminemia, it causes hypocalcemia, total serum calcium is low, then we call it factitious hypocalcemia. Once the diagnosis is confirmed that it is true hypocalcemia, then this is the most important thing, that order a serum hypocalcemic panel. I have made another slide for this because I want to highlight this. Then we order a test. Sometimes only we order a test for active form of vitamin D. This is of limited value because the turnover time is we don't do it usually, but sometimes we have to do it. So what is hypocalcemic panel? So whenever we have a hypocalcemic patient, we should do these tests. Tests are very important to find out the cause. Most of the time, we will be able to get near our diagnosis by doing this test. So we'll do a serum albumin, we do serum phosphate, we do alkaline phosphatase, magnesium, creatinine, PTH, vitamin D, urinary calcium to creatinine ratio. These will somewhere, it will point us where. So serum albumin will know true hypocalcemia or false hypocalcemia. Serum phosphate, alkaline, for we know in vitamin D the phosphate goes high, otherwise in most of the phosphate is low, otherwise in many of the like renal and all the phosphate is high. Alkaline phosphate is again high. Magnesium, if it is low, then we have to treat magnesium, so it could be a magnesium responsive hypocalcemia. Creatinine will tell us about renal status, and PTH intact is done to know the response of hypocalcemia, and I will tell you again with the flow diagram. Then vitamin D, urinary calcium to creatinine ratio is again very, very important. So suppose our phosphate is low. If the phosphate is low and calcium is also low, it most of the time, it almost always indicates vitamin D deficiency. But if the calcium is low and the phosphate is high, then parathyroid gland is not producing or releasing parathyroid hormone, or both, or that parathyroid is not having the correct effect on it. That means it could be a hypoparathyroidism or it could be pseudo hypoparathyroidism. Right? Calcium is low but the phosphate is high. Then if when we do parathyroid is if it is low or normal. Usually if there is hypocalcemia, parathyroid hormone should be high. But if it is low or normal, both means that the parathyroid is not responding, not giving adequate response to our low calcium. That means therefore a diagnosis of true hypoparathyroidism. Primary hypothyroidism, just leave this. Then if it is parathyroid hormone is high, then we know that it is responding to our calcium, and that means there is no problem with the PTH. Calcium creatinine ratio is very important because whenever the PTH is acting, it is trying to reabsorb calcium in the renal tubules when there is hypocalcemia. So in ideal situation, when we do a urinary calcium creatinine ratio, the calcium in the urine should be low. That means calcium creatinine urine ratio should be low. If it is low, that means we are the parathyroid hormone is acting and it is normal. So appropriately high levels of parathyroid should result in low calcium creatinine ratio, and because of calcium retention. A normal to high ratio, particularly if combined with high serum phosphate, suggests that it is unresponsive to parathyroid hormone. That just a minute. It is not responding to parathyroid hormone because calcium is not getting retained in the kidney. So it could be profile. It is hypoparathyroidism, but it's called pseudo hypoparathyroidism. That means PTH was high, but it is the calcium creatinine ratio is not calcium creatinine ratio is normal or high. That then there is a problem with the parathyroid hormone, and we need to whenever there is a problem with the parathyroid hormone, we need to consult the endocrinologist. Then 25 hydroxy vitamin D, parathyroid is high, calcium is low, phosphate is low, we have low vitamin D, we know that it is vitamin D deficiency. Cause could be anything, cause could be decreased intake, cause could be hepatic, cause could be anticonvulsant drugs, but it is because of vitamin D deficiency. But sometimes the vitamin D is normal, but calcium and phosphorus are appropriate, but 120, then we have to do 125 hydroxy vitamin D sometimes only, because that if it is low, that means this 1 alpha hydroxylase is not working. That means there is a mutation in this 1 alpha hydroxylase. And if 125 hydroxy is high, that means it is the organs are not responsive. We have 125 hydroxy, organs are not responsive. That means there is a defect in the receptor. These conditions are very rare, and we usually do not we don't have to do 125 dihydroxy vitamin D, because from the above battery of tests we can mostly we come to a conclusion that whether it is a renal thing, or it is because of hypoparathyroidism, or because it is because of vitamin D deficiency. Usually we come to know through this. Other tests we do ECG, we do limb radiographies. This karyotype test we do in infancy. Then family screening sometimes for calcium sensing receptors abnormality, to see the bone density, DEXA scan and BMD. Sometimes we do to see the skeletal health. But main thing to diagnose the cause is this. So what skeletal manifestation it may cause? It can cause osteopenia, rickets, or osteomalacia. It can cause pseudofractures. It can cause pathological fractures. So these are like pseudofractures. Sometimes these lines are there which are hyperlucent and which has a sclerotic boundary. They are mostly symmetrical, and they are seen in the shaft of the femur or the pubic rami. So they are there is some softening of the bones, and then there is again remineralization. So this is a finding of pseudofracture. They are not fractures, they are pseudofractures, and this is a finding of osteomalacia. Then they also say there is a since I'm talking about adolescent, in adolescent there are two types of adolescent: one who are obese and one who have low BMI, less than 18. So one who have obese, their skeletal manifestations, because they have very good bone mass, their intake of calcium is good, the intake of vitamin D is good, then they do not have much of osteopenia, but they have this cyst like presentation in the long bones. And children who have low BMI, whose dietary intake is not good, they have more of osteopenia like picture. So then the most common cause which we found here was vitamin D deficiency. The hypocalcemia, we found low calcium, low phosphorus, and we had done PTH. There was high PTH. The calcium creatinine ratio in the urine was low. So the vitamin D deficiency was diagnosed. Now this vitamin D deficiency, we know that different bodies have different cutoffs. The Medicine Society, the Endocrinological Society, the Osteoporotic Society, but mostly they range from 20 nanogram per ml to 30 nanogram per ml. In I think Lal they give in nanomole, that is 50 nanomole, that is 20 is equivalent to 50 nanomole to 75 nanomole. Then there are levels of insufficient, deficient, but this is roughly a cutoff of vitamin D deficiency. They say 12 to 20 is insufficient, less than 12 is deficient. But if we are having a symptomatic thing, any level would be even this will be deficiency for us. So what happens when vitamin D is there? The calcium absorption is 40%, or the dietary whatever calcium we take, the 40% calcium is absorbed. But when vitamin D is not there, only 10 to 15% of calcium is absorbed in our gut. So why we have seen more of vitamin D deficiency during this time? Probably because of COVID, less exposure to sunlight, less people were less outside. Maybe the diet was not proper, there was no routine. So and otherwise also in adolescent, lack of sunlight exposure, pigmented skin, low intake of vitamin D, all these caused vitamin D deficiency in adolescent. Remember that in adolescents, since their bone mass is good as compared to younger children, the biochemical markers are less affected. Their calcium could be less affected, their phosphorus could be less affected, their vitamin D might not show so so low. So the biochemical marker, not vitamin D, calcium phosphate, alkaline phosphate is. So their bone thing is less affected because their bone density, bone health is very good. Otherwise, they have good bone mass. So what are the clinical manifestation of VDD? That means vitamin D deficiency. It depends what is the severity of deficiency, what was the duration of deficiency, what was the speed of growth. If in adolescent period the demand is more, so the speed of growth is more, so the calcium demand is more. How much calcium the child is taking, how is the absorption. So all these will affect the vitamin D deficiency manifestation. So this was one. There are some cases I have picked up from net only. That a patient was having low serum calcium, low phosphate, low 25 hydroxy vitamin D. So with low dietary intake, vitamin D deficiency ticket was the diagnosis. One patient had high level of phosphate and very high level of parathyroid hormone. That is also revealed normal 25 hydroxy vitamin D and high ratio of calcium to creatinine ratio. So it is consistent with parathyroidism, except for a high level of parathyroidism, because it is the parathyroid hormone is high, but other picture is like a hypoparathyroidism. So it is pseudo hypoparathyroidism. So he had other features of Albright syndrome, Albright, this short stature, obesity, round face. So this is pseudo hypoparathyroidism, where PTH is high, but it is not the end organ is not responding to PTH. Then there was one patient with high level of phosphate but normal of magnesium and parathyroid hormone. This is hypoparathyroidism. So now, so this is roughly, I have given a brief review that what are the causes of hypocalcemia, what is the pathophysiology of calcemia, where the things can go wrong, and what is the battery of tests which we should usually do to reach a diagnosis of parathyroidism, to reach a diagnosis of hypocalcemia. Treatment wise, whenever the patient comes in symptomatic in severe hypocalcemia with tetany or with erythema, so the emergency treatment, we give IV calcium, magnesium, then sometimes phosphate lowering agents are given, vitamin D analog, supplements with calcium and vitamin D, diet. So these are mainly the treatment modality for hypocalcemia. Emergency treatment, we give IV calcium, calcium gluconate is usually given. Calcium chloride is not given. It has got very high concentration of calcium, and it really irritates the vein. If sometimes it has to be given in adults, they give. Sometimes then it is given as in central line, but usually it is not given. So IV calcium gluconate is given 10 to 20 ml. We give diluted in. Otherwise, in younger age, we give 1 to 2 ml per kg. But in adolescent, we can give 10 to 20 ml diluted with 5% dextrose in water or saline over 10 minutes. Then we can give it as a intermittent infusion, or we can give it as a continuous infusion also. Whenever we give as a continuous infusion, there should be cardiac monitoring, and we check calcium every 4 to 6 hourly, so that once the calcium level rises, then we can stop it and we can continue as intermittent, or we can shift to oral. Oral therapy is started very soon in the treatment of when we are starting IV calcium. Then also on day 2 only we start oral calcium and oral vitamin D also. If when we do if the magnesium is also low, we must give IV magnesium as infusion. We give as 25 to 50 milligram per kg as infusion. We have a 50% of magnesium sulfate, that is in 1 ml there is 500 milligram of magnesium. So in adolescents, roughly they are more than 40 kg, so we give 2 ml of 50% magnesium sulfate as infusion if hypomagnesemia is concurrent with the hypocalcemia, because till we do not treat magnesium, the hypocalcemia will not be treated, will not come to normal. After giving this, then we come back to, we start oral calcium. In adults, mostly they give 1 gram per day elemental calcium. Different preparations are available, gluconate, carbonate, phosphates, but mostly calcium carbonate is preferred. Calcium carbonate has a high level of high concentration of elemental calcium is more. 40% of calcium carbonate is elemental calcium, so calcium carbonate is preferred. Then we give vitamin D analogs. If it is severe hypocalcemia, vitamin D is very low. Even in vitamin D deficiency, we have given calcitriol. Mostly we give 0.25 mcg per day, for we give it for a week or two, and then we so along with that we start cholecalciferol, and after that we stop this calcitriol, and we continue with the cholecalciferol. We give the required dose. In hypoparathyroidism, in renal disease, where the active form will not be formed, where the 125 vitamin D will not be formed, there the endocrinologist and the nephrologist, they usually start calcitriol in a dose of 0.5, 0.25 or zero point 0.5 or zero point 0.5 BD also in a day. So that is usually started by nephrologist and the endocrinologist, calcitriol in renal rickets and in hypoparathyroidism. Then we give vitamin D. We all know we give cholecalciferol. Different preparations are available. There are sachets available. There are liquids available. So there are different regimes which are available. In adolescents, mostly we give 60,001 unit for 10 days. We can give daily also. There is a regime where they say they give 60,000 every weekly for 6 to 8 weeks. There is a regime there where they say you give it daily, you can give it 3 monthly. So there are different regimes. Mostly when a child is when an adolescent is admitted in PICU with symptomatic hypocalcemia, we are giving it daily for 10 doses, and then we give the maintenance dose. Maintenance dose, they say 600 IU per day, but many times we have to give 2000 to 2000 international unit per day to maintain the vitamin D in a normal level. So these are the main things which we give. Then if there is hypoparathyroidism or if there is renal rickets, then suppose if there is hypoparathyroidism, definitely we involve the endocrinologist. Then they give intact parathyroid hormone also. They do their own monitoring. They do their monitoring of calcium creatinine ratio, because their calcium monitoring is not enough for them. Many times calcium is secreted more in the urine, and there are risk of nephrocalcinosis. So they monitor calcium creatinine ratio in the urine every 3 to 6 months. So then we refer the patients to endocrinologist and they take over. If there is renal rickets, then definitely the nephrologist is also involved and they monitor. So these are mainly the therapy for hypocalcemia according to course. So take home messages: it is not uncommon presentation in adolescent. We must know the interplay of various factors, must do hypocalcemic panel. I think that is the most important thing which we should do in any hypocalcemic patient. Even if it comes in a OPD and we want to find out the cause, we can do the hypocalcemic panel. They are very regular tests which we can do. And whenever there is hypoparathyroidism, there is renal rickets, there is some genetic problem, then involve endocrinologist, nephrologist, and geneticist whenever indicated. Thank you.
Thank you, Dr. Neeta. It was a very extensive and a wonderful presentation. And the explanation of the metabolism, the calcium and the parathormone and the vitamin D was one table that was very much required, because that is the essence of the talk. If one knows about how the pathophysiology, how the hormones work, then one can correlate very well what receptor defect is there and how it goes. There is one question in the chat box from Dr. Puneet Kumar. He's saying, how does alkalosis and acidosis both can cause hypocalcemia?
Yes.
Is it possible that acidosis and alkalosis both can cause hypocalcemia?
Yes. Even acidemia can cause. There could be hypocalcemia in acidosis also, if there is because there is the ionized calcium becomes more and the total calcium becomes low. In acidemia, we have to treat hypocalcemia first, because if we do not treat hypocalcemia first and we treat acidosis first, then the calcium, the ionized calcium goes inside. They get bound.
Hence the binding, actually.
The binding, yeah. So
Yes.
the acidosis can alkalosis, definitely it causes hypocalcemia, that we know. Even hyperventilation also causes.
And there's one comment from Dr. Vikas Taneja, sir. I welcome Dr. Vikas Taneja. Sir has commented about bone densitometry, where he has commented that most of the DEXA scans and the bone mineral density machines are calibrated for age greater than 20 years. So practically not possible to interpret correctly in children.
Yes.
That was just one comment which I wanted to share with the audience. We have Dr. Prashant Seth, Vice President, IAP Delhi, and also currently President-elect IAP West Delhi. Dr. Prashant Seth, I would like you to say a few words.
Yeah, first of all, I would like to thank Dr. Neeta for a wonderful presentation, and Dr. Gaba and Dr. Richa for organizing these events. Really, we are thankful to the whole team. And one thing which I would like to ask Dr. Neeta, or rather comment on this, you said alkalosis causes hypocalcemia, like hyperventilation and all, it can cause tetany, we all know. But basically, it is not, total serum calcium is not low in that. It is the ionic calcium component which is low in that.
Right, sir.
So we have to
You don't have
differentiate
to
the
treat
two.
it.
Yeah.
The
So
hypertension.
that differentiation is also very important. The total serum calcium and the ionic calcium.
Yes, definitely.
In hyperventilation, whenever there is or alkalosis due to any cause, it is basically the ionic calcium which becomes low. And all the symptoms of hypocalcemia are basically because of low ionic calcium. So more important is the ionic calcium, not the total calcium.
Dr. Neeta, actually, Dr. NP Singh, just to make it more easy to understand, actually, the main science behind is that there is a slightly difference between the manifestation of acidosis and alkalosis, both causing hypocalcemia. In alkalosis, now usually it is the respiratory system which is responsible for that. So what happens that during alkalosis, there is a increased binding of albumin with the calcium. So that's why total effective ionized calcium, which is the active form of the calcium, becomes low because it is most of the calcium has been bound. So ionized calcium is low, and that's why causing the symptoms, whatever it is, a tetany or like that. But in contrast, contrary to that, in case of acidosis, usually it is the metabolic acidosis. So here kidney is the involvement. So here there is a functional disturbance during the uptake of the calcium. And that's why calcium is excreted in the urine. So there is a hypercalciuria. And this hypercalciuria is leading to the hypocalcemia. So totally there is a difference between the cause and effect related with the calcium in case of acidosis and alkalosis.
Yes, sir. Thank you, sir.
Another thing which I would like to ask Dr. Neeta, you said you started the treatment with IV calcium if hypocalcemia is being noticed. So is IV calcium needed in all cases? It is only needed in symptomatic cases.
It is only needed in symptomatic cases. If the child presents with seizure, if the child presents with carbohydrate spasm or tetany, then only it is needed. Otherwise, in OPD practice, we can just supplement with oral calcium. We do not need.
And another comment I would like to say, basically, as we mentioned that the commonest cause of hypocalcemia in adolescents is vitamin D deficiency. But vitamin D deficiency does not usually lead to so severe hypocalcemia, which leads to symptomatic condition. So generally vitamin D deficiency may be there, but serum calcium levels are generally normal. If you see exactly percentage wise, I cannot tell you, but by clinical experience, you get the profiles done. Vitamin D levels may be low in many patients, but calcium levels are very unusually low. I mean, in very unusual patients.
Sir, actually, the common causes of hypocalcemia are more seen in PICU settings, where the patient is sick, where the patient is renal failure. We see more hypocalcemia there.
Yes, it is more seen there.
Yes, more seen there. But in these days, we have seen, good with no morbidity, nothing. The patients coming, adolescent patients coming with hypocalcemia, and we have found vitamin D deficiency as the cause. Otherwise, definitely, it is more in the PICU setting where we get hypocalcemia.
So
there has been a spurt.
We can contribute this to the cause that in the past 2 years our children have not gone out that common. Can we contribute that to the COVID times?
Yes.
Maybe their diet also. I think the adolescents they've turned into monsters.
Ours is a population which is already
not listening to their parents, and they are eating everything what they can eat, but not the right diet.
I think Dr. Prashant, you were right. Hypocalcemia in vitamin D deficiency, usually we don't see much. You were very right to say. Vitamin D per se, most of the OPD patients will have normal serum calcium levels or slightly low, which are usually asymptomatic. But yes, this time we are seeing unusually low calcium. I mean, still we are not able to explain why.
Is the duration important? I think it is the last stage when the calcium goes low in vitamin D deficiency. If the vitamin deficiency is prolonged, then the calcium level will decrease. No.
Yes, should be, because there is a lot of homeostasis is maintained for a long time. For the calcium to go low, it really takes time. PTH goes very high by the time we detect hypocalcemia.
That is
So
why
it takes
See, because calcium has to be used in other like muscle contractions, cardiac, all activities. So body will always try to maintain serum calcium levels as far as possible. Only in prolonged duration, severe, and we last patient what we saw had severe osteopenia. Probably the bones were also empty. So overall calcium level in the body might be very, very low. That could be the reason.
there was a fracture also in that patient. Fibula fracture was also there. So
We have seen lot of knock knees coming with this. You might have seen many girls having knock knees.
Knock knees. Okay.
Yeah,
okay, yes,
Yeah. Okay.
yeah,
yes.
Yes, even the adolescents. And,
Right.
yeah.
even when we get the X-ray knee done, we don't find anything, and we usually find it in the X-ray wrist only, the presentation.
Yeah.
Yes. Another thing, Dr. Nita, just for discussion, see if we get a case
Yes,
of
sir.
vitamin D deficiency with, say, normal calcium levels, would you like to give calcium along with vitamin D, or only vitamin D is sufficient?
D along with calcium, because there will be mineralization will be more than the calcium demand will increase. So we will give calcium for some time.
But is it essential?
Yeah, it
If
should be
diet
given.
is adequate and
Diet,
calcium levels are normal, then
actually, diet we cannot ensure correctly. So if we feel that mineralization because the bone will demand more. Once we start giving vitamin D, so usually we give calcium along with vitamin D for at least for some time.
No, actually, I just beg to differ in this concept that we used to be treated in our PG's days like whenever you give the mega dose of vitamin D, you must give the calcium. But I had not find any one literature which suggests this theory. So this was stipulated that it is just allied to the Hungry bone syndrome. So it was postulated that the sudden release of this by giving vitamin D, which called Hungry syndrome, but it is not there. Hungry bone syndrome is exclusively related with the hypoparathyroidectomy. So unless there is a documented hypocalcemia, there is no any indication or dictum to give the calcium along with vitamin D. But as it is usually given since a long time, we used to have the practice to give it. But it is I didn't find any literature which suggests that whenever you give the supplementation of vitamin D, you must give the calcium. If someone has encountered, please enlighten on that.
Exactly, that is what I wanted to specify.
Sir, ideally speaking, though, for normal children, we don't need serum, the calcium suspensions at all. But what we usually see that children are taking, parents are giving calcium suspensions to children right up to 5-6 years, they are getting it. So from that logic, ideally speaking, calcium is not required anywhere if they are taking adequate amount of calcium in the diet from milk or from other sources. So even if we are giving vitamin D and if we are not giving oral calcium, it doesn't make a difference.
So then our OPD prescriptions should not have calcium. I think we should considerably reduce the writing of calcium on our OPD prescriptions. Either we get the serum calcium done for all the OPD patients and then prescribe. Would that
or it's unnecessarily causes constipation. It's a very known entity. When you give the calcium, it is tend to causes constipation
and vomiting also.
Normally, we are not writing calcium preparation. We only give vitamin D. Even in newborn stage, people, mothers keep asking calcium saath mein dena hai. Yeah, during dentition, we say no, calcium is enough in the diet because they are milk basically. So we say just vitamin D is essential for the absorption. We don't give calcium.
This is what I wanted to specify when I raised this question, because calcium is not always essential, except in when we talked about neonates, it is premature babies. We do need to give calcium supplement. In premature babies, we do need to give calcium supplement.
But at that time, sir, also we should supplement the vitamin D that we usually do usually not doing in our neonatal patient. We are only giving the calcium. But ideally, at that time, also one must know the vitamin D level if it is possible, and it should be supplemented because we are giving the 400 IU.
But as a
Vitamin D is a natural practice to give these days.
It is
We are giving to all-
routinely given. Yeah.
Till 1 year we are routinely giving. We are routinely.
No, I am talking about the case of documented neonatal hypocalcemia, where we used to supplement with that thing, but we are only giving the 400 IU. That is the just maintenance dose, because the milk does not contain. That is the separate story. But at that time, whenever hypocalcemia is there, we must also document the level of vitamin D, which we usually not doing. We are not going for the vitamin D level in neonates. So only supplementing as a just maintenance dose for reduced amount in the milk. That is my concern, because nowadays whenever we are working up for the neonatal hypocalcemia, usually a vitamin D level should also be checked.
Okay.
Right.
Yeah. Because the breast milk is as it is deficient.
So we had one study which was started by one of the DNB students in Fortis. So where they tried to look at the vitamin D levels in all term as well as premature babies, especially those with documented hypocalcemia. So again, the proposed theory was that they are presenting with severe hypocalcemia because of vitamin D deficiency. And vitamin D deficiency cannot be corrected by just giving the routine maintenance dose of vitamin D.
That's
you will
my
need
concern.
to give
Yes.
high dose vitamin D for that.
Certainly. That was my concern.
And for how long you need to prescribe them? Beyond 1 year, how long?
Then the mega dose therapy is the same, duration is the same. Then
Your voice is not clear, sir.
Yes, sir, your voice is not clear. Dr. NP Singh, sir, your voice is not
there is no any difference in current mega dose. Or if you are actually, the duration is only thing is that in neonatal you have to do the few more times to document the normalization of the vitamin D level. So first instances, what we are usually giving in the pediatric dosage, the duration is the same for neonate also. But we usually, there is no recommendation that after correcting for 8 weeks or 6 week dose, we should go for the repeat test. In pediatric practice, we should not do, or you usually not doing. But in neonatal period, ideally you should document after completion of the dose that whether this deficient level has been corrected or not. So I have encountered this thing in some neonatal journal. So I'm not sure, but neonatologist fellow can give exact value. But the duration is the same. You have to give the correction dose of 6 to 8 weeks. Whether you are choosing as a little dose per day, 1000 unit or 2000 unit, or give the weekly dosage. That is different. But we have to correct accordingly as equivalent to the pediatric regimen.
Okay.
Right.
Even the neonates.
Yes. I am talking about neonatal period.
Well taken, sir. Any other comments anybody would like to give? Dr. Uttampal, sir.
Somebody is asking here about calcitriol in vitamin D deficiency. Though in literature I did not find anywhere about calcitriol in vitamin D deficiency. I found more in hypoparathyroidism and renal rickets. But yes, in acute we are giving calcitriol. We give 0.25 microgram. We have given for a week or 2 weeks, and then we have withdrawn that and continued with cholecalciferol.
No, but Dr. Neeta, calcitriol is normal the vitamin D only.
Yeah, vitamin D only. It's the active form of vitamin D. So that we are giving in vitamin D deficiency also. That's what I'm saying. But most of the literatures, they have mentioned more calcitriol more for hypoparathyroidism and renal rickets. And
because kidney is not able to make the 25 hydroxy.
Yes,
This
yes,
around 125 hydroxy.
Yes. And about the target serum calcium, it should return to normal. But in practice, in last 2 patients, our calcium did not return to normal before we stopped the IV calcium. It was around, the patient was around less than 4 and it reached around 5, but the patient became asymptomatic. And then we observed the patient once in the ward for 24 hours. The patient was fine, and without normalizing, we had sent. Right, sir? Taneja, sir?
Yeah. Well, it can take a longer time for the IV levels to get normalized.
Yeah.
But we have to only treat the symptoms. If the technique is corrected, if there are no cardiac issues, then rest all treatment can continue. Vitamin D has been given, oral calcium can be supplemented, and they can be sent.
Dr. Neeta, actually calcitriol can be given in case of vitamin D deficiency or deficiency also. There are certain indication of that. Whenever there, whenever there is a marked deficiency of vitamin D, and particularly if it is associated with the low bone mineral density. So whenever this case happens or associated with osteoporosis like condition in some metabolic bone diseases, then calcitriol has definitely a role in case of documented hypovitaminosis D also. So it is rarely, but it can be given if you
So we are given in all
documented
the
there
three
is a
or
low density. Yes.
So I'll just I just
three, four
mentioned
patients
in
we
the
have.
chat also, I had a discussion today with the radiologist because this patient we had ordered for a bone mineral density, but I was categorically refused by the radiologist that bone mineral density cannot be done in less than 20 years of age because the machine is not calibrated to give the correct reading. So if a child is say 16 years or 15 years or 14 years, they don't advise to get a BMD done. So practically, they just want that you can look at the X-rays and bone mineralization, and that's all. That is the only support we have. In adults, like we look at the criteria of bone density, where they have the Z scores and everything. So they are not calibrated for children. So there is no point doing it or getting or acting based on the BMD reports.
But what is the other way of knowing the bone density, Dr. Taneja?
Nothing, only X-ray. And you can give calcium. We give calcium, vitamin or vitamin D, and then we can repeat X-ray after say 3 months or 6 months to see whether bone mineralization is better or not. Just like we used to look at the healing line of rickets. I think that only makes sense.
In fact, BMD
We
is
also
recommended
do
only
one
for adult osteoporosis.
dental X-ray.
You had.
No, but it is true for everybody, or our radiologist or our Indian setup or our lab is not calibrated, because is it a general rule that it cannot be done
No, it's
below
not.
the 20 years?
It's not the lab, it's the machine. Machine
Okay.
is not calibrated less than 20 years. So I will have to find out whether it's a specific machine or every machine. I have no idea. But this is a recent information which I was also a little surprised that it is also age dependent.
Dr. Taneja, the reason of this is basically BMD machines were designed to detect adult osteoporosis, particularly postmenopausal and senile osteoporosis.
Right.
So
Yes.
they were calibrated for that purpose.
Yeah.
The Z scores must be for that only, na?
Yeah.
According to that age. So we have to find out Z scores for different age groups then.
Yes.
Data should be there for that.
Yeah.
It was also written somewhere that BMD doesn't differentiate between osteoporosis and osteomalacia. Only with the, it's not very easy to differentiate. Both the conditions are very different actually.
No, but actually in that case,
children.
In that case, your
voice is
will help you to differentiate, because there is hardly any relation with vitamin. So in that way, you can correlate with that.
So excellent discussion, Dr. Neeta.
Thank you, Dr. Neeta. It was an excellent presentation. And I also thank Dr. Vikas Taneja sir, Dr. NP Singh sir, and Dr. Prashant for such an interactive session. And I extend my word of thanks to our president sir, Dr. Gaba, and our technical expert, Dr. Vipul Jain, the backbone of our IAP, Dr. Uttam Pal sir, and all the participants who have logged in. Specifically, all those who have interacted very well. And because these meetings hold no meaning if our participants are not there. Thank you very much. And we look forward to organizing more of the physical CMEs also in the near future. And on 24th of February, we are holding a workshop from IAP Delhi on interpretation of CBCs at Genesis Hospital from 2 to 5. It's a certified workshop, and I request all of you to please log in, to please get yourself registered.
Not log in, you have to come physically.
Physical registration. And we are also holding a virtual panel discussion on Down syndrome. It will be from the Down Syndrome Parental Society. And we have speakers who are parents who have children from Down syndrome. And I request you to please log in. It's a virtual platform where we will all learn as pediatricians how to break the news of this Down syndrome to a parent, how it is to be done in a proper manner. I now end this meeting. Thank you very much to all the participants.
Thank you.
Thank you so much.
Excellent. Thank you, Neeta. Thank you so much for
Thank you,
informative.
everyone. Bye.
Thank you.
Thank you, sir. Thank you.